Please stand by. We're about to begin. Good day and welcome to the Foundation for a Healthy Kentucky, Kentucky Programs and Data on Drug Overdose conference call. Today's conference is being recorded. At this time, I'd like to turn the conference over to Rochelle Seeger. Please go ahead.
Thank you. Good afternoon, everyone. So glad you joined us today for the Health for a Change, our webinar on Kentucky data on drug overdose. My name is Rochelle Seeger. I'm honored to work at the Foundation for a Healthy Kentucky as a Community Health Research Officer. The Foundation began in 2001, and we've been working to improve the health of Kentuckians through policy change and community investments. We're a nonprofit philanthropic organization created with the assets from a settlement agreement between Anthem and Kentucky Blue Cross and Blue Shield. We do the work in Kentucky through grant making, health policy research, and trainings just like this one. This training series called Health for a Change is to meet the needs of you, all the people across Kentucky who are doing work in coalitions and communities and health departments and the state of Kentucky across on all different avenues to improve the health of Kentuckians. Here are the strategies by which we do our work: by working on policy, improving access to care, reducing health risks and disparities, and promoting health equity. On the Foundation's website, you'll see healthy-ky.org, the tab with events. You can sign up for the different events that we're holding, including the archive of this training series, Health for a Change. You can also sign up to join the Foundation's mailing list if you're interested in joining that. To save the dates before we get started, on September 25th in Lexington, Kentucky, we'll be hosting the annual Howard L. Bose Memorial Health Policy Forum, a topic that I know will be interesting to all of you. The topic for this 2017 forum will be Kentucky Substance Abuse Crisis Solutions and Strategies. You can see that red arrow I pointed to our events tab, and then down below you can just click to register for the webinar through the Foundation's website. Again, that'll be Monday, September 25th in Lexington, the Howard L. Bose Memorial Health Policy Forum. Finally, I'm hosting the Foundation, I'm organizing the Foundation and Interact for Health, another health foundation that serves the greater Cincinnati area, is proud to sponsor Data Forum. All of the data lovers on will want to mark their calendars for Monday, October 23rd. We'll be in Erlanger, Kentucky at the St. Elizabeth's Training Center. We have a great lineup of speakers that will be talking about health improvement, and how they use data to improve health in the Kentucky and Ohio areas. I'm thrilled to have a great series of speakers this morning, Kentucky experts on the data we have about drug overdose in our state. And our first speaker today is David Hopkins. He's the program manager for the Kentucky All-Schedule Prescription Electronic Reporting System, known as KASPER. I'm thrilled that David will be on the call this morning. David, welcome. Go ahead.
Thank you, Rochelle. Good afternoon, everyone. I'm very pleased to give you an update on one of the tools that we have. I know you all are aware that we're suffering through a terrible epidemic with opioid abuse that is resulting in increasing drug overdose deaths in Kentucky. So I want to talk about the Kentucky All-Schedule Prescription Electronic Reporting System, or KASPER, which is one of the tools that we have that we're using to try to help combat this epidemic. The KASPER program is housed in the Office of Inspector General in the Kentucky Cabinet for Health and Family Services. I can view these slides, by the way, but since they can't turn control over to me, I'm going to have to ask Rochelle if you will please advance me to the next slide. There we go. Kentucky's Prescription Drug Monitoring Program, KASPER, tracks Schedule 2 through 5 controlled substance prescriptions dispensed in or into Kentucky. It provides a real-time web access database that really is, again, a tool to help us address the misuse, abuse, and diversion of controlled pharmaceutical substances. I want to give you a little history, just going back a little bit on how KASPER came about. Back in the early and mid-90s, we were suffering through a terrible problem with the abuse of controlled substances and prescription drugs, to a large extent in eastern Kentucky. That was almost ground zero for it. So in 1997, an Attorney General's task force recommended development of a prescription drug monitoring program that ultimately became KASPER. Now, by the way, the Attorney General at that time is the President and CEO of the Foundation for a Healthy Kentucky Ben Chandler. So the legislation was passed in 1998. The program came live in 1999, in July 1st of 99, and processed about 3,105 report requests during the first 6 months. Over the next couple of years, the system really got bogged down because so many individuals, practitioners, and other authorized users started requesting reports that in 2003, the legislature allocated funding to create what ultimately became one of the first web-based self-service prescription monitoring programs in the nation, and that was called Enhanced KASPER, or eKASPER, was launched in 2005. One of the other big milestones in the history of KASPER came in 2012 when Kentucky became one of the first states to actually mandate registration and usage of its prescription drug monitoring program. Next slide, please, Rochelle. I'm not sure if all of you are familiar with, when I talk about all schedules and Schedule 2 through 5, the controlled substance schedules. These are schedules controlled by the Drug Enforcement Administration. The lower the number on the drug schedule, the higher the potential for abuse and addiction. So Schedule 1 drugs are illegal drugs according to the DEA. They include heroin, marijuana, ecstasy, and so on. Now, I know many of you might be looking at marijuana saying, well, wait a minute, isn't that legal in many states? It is in some states. It is not here in Kentucky, and according to the federal government, the DEA, it is an illegal drug. I won't go in. That's a whole other webinar to talk about that. Now, Schedule 2 drugs, those are legal drugs. They can legally be prescribed by a practitioner. Very high potential for addiction and abuse. They include the powerful opioids such as oxycodone and hydrocodone, brand names such as OxyContin or Vicodin. They also include some of the stimulants that we use for treating individuals for ADD and ADHD, drugs like methylphenidate or Ritalin and amphetamine or Adderall are Schedule 1 controlled substances, and then some other drugs such as fentanyl. You'll hear a lot about fentanyl contributing to a lot of these drug overdose deaths. Not all of that is legal fentanyl in the form of brand names such as Actique and Duragesic. Much of that is illegal fentanyl coming into the U.S. from other sources. Now we go to the Schedule 3 controlled substances, a little bit less abuse potential than Schedule 1 or 2. Typically those are drugs such as testosterone, and then also interesting drug buprenorphine naloxone, which is a brand name Suboxone, which is an opioid that is actually used for treating substance use disorder, for medication-assisted treatment of substance use disorder. As we go down the schedules to Schedule 4, less abuse potential than the other drugs. Typically those are our benzodiazepines or tranquilizers, such as Valium and Xanax. And then lastly, we have the Schedule 5 controlled substances. They have the least abuse potential, but certainly are abused in many, many ways. And those are typically drugs such as codeine-containing cough mixtures. Next slide, please, Rochelle. The way KASPER works is that the dispensing of these Schedule 2 through 5 controlled substances is required to be reported to KASPER. We get over 10 million records per year reported. The dispensers have basically until the end of the next business day to report. So the data in KASPER can be somewhere between 1 and 3 days old. The system operates 24/7. And it's available by an authorized user from any PC with web access. And they can typically get a KASPER report back in about 30 to 45 seconds. Next slide, please, Rochelle. It's very important to understand what information is actually tracked in KASPER, what's available and what is not available. So here's what's in the KASPER system. Again, any Schedule 2 through 5 controlled substance dispensed at a retail pharmacy, and that could be in Kentucky or outside, such as mail order pharmacies. They are required to report and are very good about doing that. Hospital emergency departments, if they dispense any controlled substance to an emergency department patient, they must report that to the KASPER system. Practitioners who actually administer or dispense controlled substances in their offices have to report that administration or dispensing to KASPER. And then the Department for Veterans Affairs pharmacies do report any dispensed controlled substances to KASPER. Next slide, please. Now here's what's not in KASPER. Methadone that is administered at a federally regulated methadone clinic does not get does not get reported to KASPER because that's actually covered under federal privacy regulations. Controlled substances that are dispensed for administration to a patient in a hospital or a long-term care facility or someone in a jail, correctional facility, juvenile detention facility, really low risk of diverting those medications, so that does not have to be reported to KASPER. Pseudoephedrine, if you suffer from sinus problems or allergies and you get Sudafed, for example, and you go to the pharmacy to pick that up, you have to show your driver's license. That information is tracked in a different system. That's not KASPER. That's tracked by the NPLEX system. That stands for National Precursor Log Exchange, and that's actually a system operated in the Kentucky Office of Drug Control Policy. Our military pharmacies, so the pharmacy down at Fort Knox, for example, does not report to KASPER. There are discussions within the Department of Defense regarding whether they need to take steps similar to VA did and maybe report that information to the state prescription monitoring programs. I think within a few years we may see DoD come around and have their military pharmacies start reporting. Lastly, Schedule I or other illegal drugs are not reported to KASPER. I can tell you we would be absolutely happy to track those drugs if we could figure out a way to get the drug dealers to report it to us. Next slide, please, Rochelle. These are the states that have prescription monitoring programs. Something might stand out a little bit there to you as you look at this. Every state in the Union, plus some of the territories such as Guam, have programs. Missouri is the only state that does not. They are working on one. I think that they are getting closer. I'm hoping to see that they'll pass some legislation and maybe bring a program up very shortly. Next slide, please, Rochelle. Now, we know that drug diverters and doctor shoppers are not constrained by state borders. So we are actually working through a system called the PMP Interconnect. It's operated by the National Association of Boards of Pharmacy to allow the state prescription monitoring programs to share data. In Kentucky, we share data currently with every one of our border states, except for Missouri, of course, that does not have a program, and many other states. We're sharing with South Carolina, Michigan, Maine, Alabama, and several other states. The ultimate goal of this is to, if you will, create a national prescription drug monitoring program so that an individual would be able to access data from any other state through this type of a network. Next slide, please, Rochelle. Some of the data. This is the number of controlled substances reported to the KASPER program by year. I mentioned earlier that in 2012 we had a major change which was mandated registration and use of KASPER. Well, you can see that the result of that is that we had an increasing trend in the number of controlled substances dispensed in Kentucky right on through 2012. After that legislation, the number dropped, and it's continued just a very, very slight downward trend over the last years. I'm not sure it'll continue to go down. I think we'll probably stay in that range of maybe around 10.5 million controlled substance prescriptions each year. At the bottom of the slide, what I've done is included a simple average, the number of controlled substances dispensed for that year divided by the population of Kentucky for that year. So the total in 2016 was 2.37 controlled substance prescriptions dispensed in Kentucky for every man, woman, and child in the state. Next slide, please. Now this is the number of reports that have been requested from KASPER by year. The number, again, continued to go up ever since that first launch with about 3,000 reports in 1999. You can see that in 2011, last full year prior to that legislation, we responded to a request for about 811,000 reports. Then you can see the jump with the mandated requirements in 2012 of almost 2.7 million. And then in 2015, about almost 6.9 million. 2016, over 7.3 million. So significant increase in the number of requests for this data from KASPER. I will point out something interesting. We talked a little bit about interstate data sharing. In 2015 and 2016, the actual number of reports requested by authorized KASPER users who signed into the KASPER system to request a report was about 5.5 million each year. The other approximately 1.3 and 1.8 million were authorized users of other state prescription drug monitoring programs logged into their home state program and using that interstate data sharing capability to say, I need to see the Kentucky data for this patient. And we'll continue to see these numbers increase as more and more states come on and start sharing data. Next slide, please. Here's our top 10 controlled substances dispensed in Kentucky as reported to KASPER. Mentioned some of those Schedule IIs. There's our hydrocodone. That is the most commonly prescribed controlled substance in Kentucky. About 36% of our top 10 prescriptions are hydrocodone. As you go down clockwise around, you'll see there's our oxycodone down around 17.3%. There's one of the benzodiazepines, alprazolam, brand name Xanax at 10.4%, and so on as you go around our top 10. Next slide, please. It's also very important to understand who's actually allowed access to this data. Our licensure boards, the Kentucky Board of Medical Licensure, for example, has access to the data for a physician. The practitioners and pharmacists, most importantly, and the vast majority of the use of KASPER is by our healthcare providers to review a patient's controlled substance prescription history. So for medical treatment of a patient by a practitioner, for pharmaceutical treatment of a patient by a pharmacist. One of the recent changes, this was legislation this year, and it took effect on June 29th of this year, was that practitioners now are actually allowed to access the data for the birth mother of an infant that they are treating for neonatal abstinence syndrome or suspected prenatal drug exposure. Prior to this time, they could only get a report on their actual patient. The legislation allowed them to actually get a report on the birth mother of an infant that they are treating. The other authorized users are Medicaid program. They're allowed access to the data for a Medicaid member or a Medicaid provider. Judges, probation officers, and parole officers administering a drug diversion or probation program have access to the data. Our Kentucky medical examiners, Dr. Ralston and his team, are allowed access to the data to help in their drug overdose death investigations. And law enforcement does have access to the KASPER data. They are not allowed to go on fishing expeditions. Law enforcement must have an open, bona fide drug investigation that specifies an individual by name. And when they sign in to KASPER to request a report, they actually have to put a case number in there, which is tracked. Next slide, please. I want to tell you a little bit now about this legislation in 2012. Next slide, please, Rochelle. What it did was it mandated that any practitioner had to actually query KASPER and get a patient report prior to the initial prescribing of any Schedule II controlled substance. They have to query the system if that patient continues treatment with that controlled substance no less than every 3 months, and they have to query KASPER before they issue a new prescription for that controlled substance or for a different Schedule II controlled substance. The legislation also required our licensure boards to promulgate additional rules and KASPER query requirements and exceptions. If you would please advance, Rochelle. Now, I'm not going to go through these in detail. I just wanted to, in case anyone was interested, I wanted to show you what the actual regulations are by profession, by prescribing profession. Each of these licensure boards has determined that they have different needs, different requirements for their licensees, so they're a little different. That when they actually have to query KASPER is a little different, and some of these other controlled substance prescribing standards that include things such as when they have to do a drug screen and so on. So I thought I would just display those so you could take a look. These slides are available if anybody was interested and wanted to know what any of those were like. Next slide, please, Rochelle. There are some common sense exceptions to when they have to request these reports. If it's an emergency situation, that's pretty much defined as a situation such as mass casualties or might be a tornado or something like that. No need to query KASPER. Practitioners can treat their patients. If it's within 14 days of surgery or within 3 days of oral surgery, there's no need for those practitioners to query KASPER. They can go ahead and prescribe for their patients. If the patient's in a hospital or a long-term care facility, they don't need to query KASPER. Patients who are being treated for cancer pain or in hospice care, no need to query KASPER. There is an exception for single doses of an anxiety medicine. A patient might be coming in to have a test or a procedure and be very worried about it. They don't need to query KASPER to be able to prescribe a single dose of that. And then if a patient gets a medication prescribed and maybe contacts the practitioner and tells the practitioner, I can't take this, it upsets my stomach or something like that, and the practitioner wants to substitute that medication, they can prescribe a different one without querying KASPER. Next slide, please, Rochelle. I just want to show you a little bit about what a KASPER report looks like. Basically, it's got information about the medication, the date it was filled at the dispenser, the drug name, dosage, the patient's date of birth, the quantity dispensed to the patient, the day's supply, prescriber name and city, pharmacy name and city. It also includes, for the opioids, the daily morphine equivalent dose level for each of the opioid prescriptions. And now at the top of the report, you'll see that we also provide them as of the last day in the report date range. They can select any date range they want. We'll actually give them the cumulative morphine equivalent dose level the patient's receiving as of that day. And we graph that, the little chart in the middle graphs that MED, daily MED over time. Next slide, please, Rochelle. This is another report now. One of the things that's interesting is if the patient receives an active cumulative morphine equivalent dose of 100 or more, we put this flag on that you can see there. And that basically indicates that the patient could be at a higher risk for a drug overdose and recommends that some additional clinical vigilance might be appropriate for that patient. And then on the last page of the report, we actually have information about how we calculate the ACME figure and on co-prescribing naloxone for these patients that have a high ACME figure. Next slide, please, Rochelle. One of the things, the last point I want to make is to let you know that patients actually are allowed access to this information. This was another change with this House Bill 1 in 2012. It used to be that patients could not see their KASPER reports. With that legislation, they decided, the legislators decided that, you know what, we're going to go ahead, if a practitioner pulls a patient report, KASPER report, and the patient would like to have a copy of it, there's no problem. They can go ahead and provide a copy to the patient, and they can place the patient, the KASPER report in the patient's medical record. So once it's in the patient's medical record, it's just like any other component of the medical record, subject to the same disclosure and confidentiality requirements as any other component of that patient's medical record. Next slide, last slide, please. There's my contact information. I know I've gone through this information very quickly. Please don't hesitate to give me a call or shoot me an email if you have questions. And with that, I will go ahead and turn it back over to Rochelle.
David, thanks so much. A lot of good information. I love the screenshots. It really gave a good example of what people who may not be providers on the phone call will see. I have one quick question for you from one of our participants. The question is yes or no. Are veterinarians required to report in KASPER when a controlled substance is dispensed?
That's a good question, and the answer right now is no. Very quickly, they used to have to report prior to, I think it was 2011. We found that that created, if you will, for lack of a better term, a lot of noise in the system because you'd actually have records showing up for the human for Fido, like Fido Hopkins or something like that. So back then we decided that it just, and also we worked with law enforcement. They said it was not, veterinarian practices were not a significant source of diversion, so we eliminated that reporting requirement. That said, we have heard some situations where there are some people hitting vet practices up trying to get medications that the humans abuse, medications for their animals that they abuse.
Great, thank you so much. And we'll answer some more calls at the end of the hour if we have some more time. I'm thrilled to have two people from the Kentucky Injury Prevention Research Center from the University of Kentucky on the call with us today. The director there is Dr. Terry Bunn. Dr. Bunn, welcome to the call.
Thank you very much. Just to provide everyone with a little bit of background on KIPRC, as we call it, it was established in 1994 as a unique collaboration between the University of Kentucky and the Kentucky State Department for Public Health. So most of the grants that we apply for are on behalf of the State Department for Public Health. The one that I'm going to be talking to you about this afternoon is our drug overdose prevention program that has been funded by the CDC's National Center for Injury Prevention and Control since 2014. One of the elements of KDOP, as we call it, the Drug Overdose Prevention Program, is that we established a Drug Overdose Technical Assistance Corps. And within that core, we are able to complete ad hoc data requests, produce a number of reports that are disseminated widely, including on our website. So we produce both statewide and county-specific reports using multiple data sources that are available to us on a statewide basis. For instance, we produce reports based on emergency department visit data, inpatient hospitalizations, mortality data, crash data that we receive from the Kentucky State Police, state workers' compensation data, and trauma registry data. We also produce what are called drug overdose county profiles. Now those county profiles, they're currently available using emergency department and hospitalization data by the county of residence. So that provides community coalitions who are working on drug prevention in their local communities, not only overdose numbers, but those that the ED visits or the hospitalizations for non-dependent abuse, dependence, as well as diagnoses for comorbid conditions such as HIV, hepatitis C, and endocarditis. We do plan to add different data sources here in the near future for these drug overdose county profiles. We also, in this slide, you can see that if you scroll over a certain county in the drug overdose reports for each county, it will give you the year, the populations, the counts, and the current rates for those counties as well. Next, we do collaborate in this program with KASPER. So we're very grateful that Dave and his crew have been working with us for 3 years now on the enhancement of KASPER as a public health surveillance system. So in that regard, what we are doing with that is KASPER produces a quarterly report, and we take that report that Dave and his group produces and actually expand it a bit, including the breakdown by age and gender. We also look at trends over time. You can see here on this slide that we track, or that we, with that comprehensive report, we look at substances such as alprazolam, hydrocodone, oxycodone, methadone, as well as Suboxone, which is that buprenorphine naloxone mixture. And Dave also, we also produce annual threshold reports that not only have the age and gender breakdown, but we also break down the data not only statewide, but also by area development district. And you can see here in the bottom figure that you can also compare dispensing rates between those area development districts for some of the common controlled substances that are dispensed. Dave already mentioned this, so I'm not going to elaborate on it, but with Bureau of Justice assistance funding and the CDC funding, the KASPER reports do now include the ACMEs as well as the trend lines for the MME dispensing over specific time periods. Other efforts that we're working on in conjunction with the KASPER program is integrating KASPER data into electronic health records. KASPER's been successful with a major pharmacy chain in the integration of the KASPER data into it, and looking to expand those current integration efforts using third-party intermediaries. So there are a few that are mentioned here: the Kentucky Health Information Exchange, RX Check Hub, and PMPI Hub. We also do a number of interventions in the community coalitions themselves, so I'm just going to run through this part very quickly since that's going to be mainly what Joe talks about in his session. But we do focus on the counties with the highest numbers of drug overdose deaths, as well as those counties with the highest rates. Now, that does not mean that we exclusively work with those counties, but that they are highest priority for interventions and technical assistance. So we not only work with those 6 counties, but to date, over the last 2-3 years, we've been working with over 18, almost 20 counties throughout the state, and we welcome any counties who are interested in technical assistance to please contact us. Joe, who is our community coordinator, also facilitates our state drug overdose prevention advisory group. And in the planning and the use of best evidence-based programs and practices, he uses primarily information and guidance that's produced by SAMHSA and CADCA, which is the Community for Anti-Drug Coalitions of America. We also, with this funding, have established the drug overdose fatality surveillance system for the state, and that draws on a number of different data sources. You can see here that in this system, we use death certificate data, autopsy report data, toxicology testing reports, coroner investigation reports. They all go into the database, and then that data is linked to the KASPER data with information on those dispensing reports, and then those data are analyzed to produce reports and to disseminate throughout the state. Now you might ask, well, why don't we just add KASPER directly to the system? It's because the number of reports is so large that it will burden the database, so that's why they are linked separately. So some of the information that we gain from death certificates, it will give you the cause of death for, I'm showing here one certificate that's acute combined drug toxicity, but when you look down at the immediate cause of death, you can see the exact drugs that were listed that contributed to that decedent's drug overdose deaths. In this case, it was clonazepam, cocaine, heroin, and oxycodone. As far as what information is available to us in the postmortem toxicology reports, I'm showing another one here, one of the reports where you can see where the decedent was positive for cocaine metabolites. I can't even read this, sorry. Fentanyl, among other things, and ethanol. So it not only gives the presence or absence of the drug that was tested for, but it will also give the exact concentration. Information from the autopsy reports includes not only those drugs that contributed to those deaths, but other coexisting conditions that may have been present at the time of death, such as this decedent also had ischemic and probable hypertensive heart disease when he died. Coroner reports also provide additional information to us. For instance, I'm not going to read that excerpt from the coroner report, but we can get information such as pill counts, the presence of drug paraphernalia, as well as the presence of other prescription drugs that may not be controlled substances that the decedent was taking at the time that he died from the drug overdose, he or she died. And the KASPER prescription history will give us that history, as Dave says, of all Schedule 2 through Schedule 5 substances that have been prescribed to that decedent. We also partner with University of Kentucky CE Central and with the Department of Criminal Justice Training for professional and academic detailing. So this table here shows that in our collaboration with Department of Criminal Justice Training, in 2016, over 900 law enforcement officers were trained on naloxone administration, And in 2015 and 2016, we provided training to advanced practice registered nurses and to physicians on in-person and web-based modules on topics such as appropriate controlled substance prescribing, the use of KASPER, the pertinent regulations and laws regarding controlled substance prescribing, as well as alternatives to the prescribing of opioids. So in total, over 1,500 medical and law enforcement personnel were trained in year 2016. This is just an example of CE Central's page where you can scroll on the left-hand side of the screen to be able to get information about the type of training that may be desired. For instance, here you can get training on substance abuse during pregnancy, as well as the overdose prevention in general. This slide shows an example of the specific trainings that are available on the web through CE Central. We also, as part of this grant, perform evaluation and cost-benefit analysis of a couple of laws and regulations that were passed in year 2012. So what I'm going to be talking about today is the evaluation of the Decedent Controlled Substance Testing Law. That was passed in 2012 that says when no other cause of death has been established, that decedent will be tested for controlled substances. So you can see here one of the outcomes that we measured to look at the effectiveness of this law was the listing of the specific drugs on death certificates after the passage and before the passage of the law to see specifically what drugs were contributing to those drug overdose deaths. In year 2010, year 2011, approximately 30% of the drug overdose death certificates in the state did not list the specific drugs that were involved. And when we look at the trends over time with the passage of the law that was passed in 2012, you can see here in year 2010 that 69.2% had the death certificate completed with specific drugs that contributed or were involved in that death. And that percentage increased over time, and at the end of 2016, that percentage has gone up to almost 81% of death certificates that now list the specific drugs that were involved in that drug overdose death. Here you can see an interrupted time series analysis, and you can see clearly that before that law was passed, it was remaining steady right around 70%, and right after the law was passed, that percentage has increased right away to around 80% as far as completion with the specific drugs in drug overdose deaths. With this funding, we've also are in the process of establishing a substance use disorder information and referral service that will be live in January 2018. That is in collaboration with a number of different stakeholders. We're working with the Kentucky Office of Drug Control Policy, the Kentucky Governor's Office, the Kentucky Department of Behavioral Health, Developmental and Intellectual Disabilities, specifically the Prevention and Promotion Branch, as well as the Adult Substance Use Treatment and Recovery Services Branch. We're working with Recovery Kentucky, as well as working with Operation Unite on this endeavor. So within this website, it's not going to be just a listing of those facilities that provide substance use treatment, but it will also be a website that contains almost real-time bed availability. So we are working with a number of providers in the state, and over 100 providers have already signed on to this website so that they will be updating their treatment slot availability on a nightly basis. And the nice thing about this website is that it will not only have the bed availability or treatment slot availability, it will have the forms of payment, the levels of care. You can choose that, the type of treatment services that you would like, as well as it will have information on the populations that are served by that particular facility, accreditation status, as well as Casey's law evaluations. And since this will be also an information service, for that part of the service, we already have over 400 substance use disorder resources collected and cataloged. They are cataloged currently in overlapping and in unique exclusive buckets pertaining to law enforcement officers, whether you're a prescriber, whether you're a social worker, if you are a first responder, as well, of course, as to information that's available to the individuals themselves with the substance use disorders and to family members. So our goal with that is to make the information that is produced by a number of different well-regarded agencies such as SAMHSA, CADCA, and Health and Human Services, the CDC, and to be able to condense that information down into 1 to 2 page fact sheets or information sheets that can be used readily by individuals and that are targeted to around a 6th grade reading level. And just to give you an example of why we have that approach of making it at a 6th grade reading level and to make it a lot of that condensed into 1 page, we received a request from the UK College of Medicine that said, you know, they had been looking at all of the treatment documents that were available and wanted to know specifically, do you have a 1-page document that very simply and very briefly outlines recovery? So I'm not going to read that whole request, but that just gives you an idea of why we added that additional information in the 1-page format. This slide here shows what you'll end up with at the end when you conduct a search. You can see the tabs across the top. You'll be able to look at the type of treatment desired, the payment method, the service setting, whether gender and sex, for instance, if you are an adolescent or an adult, the facility type that is desired, whether it be a detox facility, inpatient treatment, or residential treatment, etc. And then over here on the left side of the screen, you can see that these would be specific listings of those facilities that would have treatment slot availability at the time that you're conducting the search. So if you clicked on an individual provider, then you would see information here coming up like on the right hand of the screen as to what type of the level of care that's provided, that payment method, the programs that they have, as well as their contact information. So that takes, a lot of over 400 facilities in the state and condenses it to a number that will be specific and targeted to the type of treatment that that individual desires. We'll also have back-end data analytics on that website so that we can keep track of the treatment slot availability, such as when the information was updated by facility, those that were updated within 24 hours, within the last week, within the last month, so that we can contact those who may not be updating on a daily basis to encourage them to provide their most up-to-date information to us. And we want to make it very simple for the providers to use, so it will include information so that all that will be required once this is up and going is that you'll submit your logging information and just simply indicate the number of slots that are available that day. Last thing I'll mention in regards to this program is that we are overlaying public health and public safety data and conducting hotspot analysis to be able to target prevention efforts in the state. So this is an example of heroin using trafficking arrests, possession arrests, overdose deaths, inpatient hospitalizations, and emergency department events, creating an index score here on the left, and on the right producing a map of the hot and cold spots. So when you're talking about heroin overdoses, and heroin trafficking, most of that is occurring in the northern part of the state, particularly in northern Kentucky. We did the same thing with methamphetamine, and you can see here the data that we used for that index score was trafficking arrests, possession arrests, precursor arrests, lab responses, manufacturing arrests, and overdose deaths. When you look at the index score, you can see, and the hot spots in the state, that it's concentrated in the southwest central part of the state. So I'm now going to turn it over to Joe.
Good afternoon, everyone, and we just want to maybe finish up with, where do we go from here after hearing the status of the epidemic? What can we do about it from a training and technical assistance point? So I'm going to share some ideas about how you can contact us and what kind of things we can help you with. So the specific technical assistance that we can offer you through KIPRC is, first of all, to get out there and just present the information on what the state trend and your local data trends are telling you about drug overdose, emergency room, emergency department visits, and things like that. But we also, the second part of what we offer are trainings to help in the actual coalition development, community board trainings for just how to run a coalition, how to establish a structure, what works, what are the best practices. Even using the KIP youth survey data to see what's going on with the young people in our community and what kind of drugs and what level of drugs and trends are going on in the schools and the community. We also like to help with program evaluation, outcome planning. I mean, it's good to have a coalition, but rather than just meeting, we're very interested in trying to reduce the numbers for a lot of these things that we've been talking about today. So how do we set those outcomes, and how do we get to achieve those outcomes? A major component of the trainings that we offer deal with sustainability planning for coalitions. A lot of times we get front-end federal and state grants, but what do we do next after the 3 or 4 years of funding is over? So we're working with some counties right now where we're developing templates to develop a social marketing plan for your coalition. And as you can imagine, a rural coalition is much different than an urban one with the amount of assistance that's available. We work with on-site training with coalitions that are specific to their needs. We do a lot of regional and county level planning, workshops and trainings, and I think one of the things we're really pushing right now is to, rather than just work with individual counties, is to do some regional workshops. And so we're looking for collaborations and partnerships at the state and regional level to hold those. And one of the last things we offer is just jump-starting coalitions out in their communities. We call those call to action presentations, where we present data and we raise the yellow flag basically and say, we need some help on this issue. So local coalitions, you see everything from drug-free communities to Operation Unite to our ASAP coalitions. But there's also criminal justice advisory boards out there. Some counties are still utilizing the Communities That Care prevention framework. The strategic prevention framework out of SAMHSA and KADCA is really popular with most of the counties across the state. Drug-free Kentucky, and there's more. There's a lot of local things going on that we will work right alongside with. Dr. Bunn has already mentioned the priority counties. I think it's really important that we recognize the fact that we're using evidence-based coalition models. You heard us talk about SAMHSA and KADCA, but there's also the Blueprints programs out of Colorado with their substance abuse reduction models, and then best practices from the CDC. So whenever we come out to your community and work with your coalition, we're using what's hot off the press and what's showing the best effects so far. So one of the biggest things that I've been seeing working with coalitions is they're addressing 1 or 2 major issues in the community, but they're not using a real comprehensive approach. So we at KIPRC, with our Drug Overdose Technical Assistance Corps, We really want to make sure that we're pulling everybody to the table that needs to be trained to fight this epidemic. So the strategic prevention framework is going to allow us to do that. A lot of you are already utilizing this model, establishing a community board, conducting a community and net needs assessment on your coalition in your community. And a lot of times the data that Dr. Bunn and David Hawkins just got done talking about goes into that community needs assessment piece. Then we develop a community action plan based on the priorities, and then we implement those evidence-based programs. And again, always evaluate your programs and your coalition process for success. We use the public health model, which means defining the problem, of course, drug overdose. It's one we're talking about today. Not just looking at prevalence data, like what the percent of overdoses are and emergency department visits, but also what are the risk and protective factors that are either putting communities at risk, or how do we enhance the protective factors out in our communities to guard against these things. And again, implement those evidence-based approaches and evaluate them. So that's the public health model. Most people know that. What a lot of people don't know is what the top risk factors for heroin use are. And just real quick, past misuse of a legal prescription opioid is usually the number one risk factor, and a lot of people transition from that prescription opioid to an illegal substance. The second one is increased availability and relatively low price of heroin in the United States. The increased availability can be going outside into your community or knowing where to get illegal drugs from and at a relatively cheap price. That's the second one. And the last one is this idea in the community that exists that some of these things that we're doing really aren't harmful, and they are. So that's a opportunity to educate the community about the harmfulness of the drugs. The last thing that I want to mention is this idea of having a community strategy. And based on SAMHSA and CADCA and the big heroin reduction summit that we had in Louisville last fall with the DEA, is talking about having a comprehensive approach to reducing drug overdose in our communities. So we have these 6 buckets or focus areas that I just want to mention to you. A lot of communities are using some of these things, but they're not using all of them, and we want to be comprehensive. Number 1 is reducing access to drugs, legal and illegal. So there's a number of things that fall into that bucket. Reducing inappropriate prescription use, and also educating, like seniors, for example, about the dangers of opioid addiction. The third one is improving drug overdose interventions, and this is working with your EMS service, your law enforcement, and just those who respond first to the scene. And what are we doing with the people, and what do we have on hand to help counteract that drug use? The fourth focus area is early intervention, treatment, and recovery. This encompasses a lot of stuff. The early intervention piece is finding those people who are high risk to become involved in illegal substances, but also what do we have for them in the way of once they ask for help, what's out there with the treatment and recovery and reentry back into the community. That's the next focus area. The last 2 focus areas, real quick, is getting mental health services to be a part of the community process. There's a definite correlation between that and illegal drug use. And the last one is using effective substance abuse prevention strategies. There are some strategies out there that are not effective, and we want to make sure that we're being ethical in the prevention field to our youth, and we want to make sure we're using prevention programs that are tested and effective. So I'll put my contact slide up here. If you think there's something that we can help you with, we would love to talk to you about any of the things we discussed today. And just bear in mind that it's kind of a first-come, first-serve and a priority basis for us. So if we can help your coalition, we definitely want to talk to you and see how we can fit in some type of technical assistance and support for you. So I hope you find some of this information useful. So Rochelle, if you don't mind, I'll turn it back over to you and let you finish out.
Thank you, Joe. And here's my contact information. Thank you, everyone, for chatting in your questions. We had a lot of good questions. Dr. Bunn, this is a question for you. The treatment availability locator, will it include both licensed and non-licensed providers?
We are currently only working with licensed providers.
Okay. And Dr. Bunn, another question for you, so stay on the line. The address for CE Central, is that a public use training website that people can?
I believe it is, yes.
Okay, we'll try to include that website in our PDF. Both for Dr. Bunn and David, a question about the data files. If someone's interested in getting more granular KASPER data or is interested in running special reports or they're a researcher, how could they get that information? Is any of it publicly available? David, would you start with a brief answer to that question? David, if your line's on mute, we can't hear you yet.
I'm sorry, there we go. Yeah, there's a whole series of trend reports that are available out on the KASPER public website if you look at the side thing on studies and reports. And there also are all of the quarterly and annual threshold reports that KIPRC actually prepares, that Terry and her team prepare. There's a ton of data in there. Now, on the trend reports that we prepare, I can actually provide that data in spreadsheet format or on an annual basis. Other than that, any other data, that's what we're publicly allowed to release. Anything else would require a formal application for a study, and it's a bit of a complicated process, but it can be done. But the trend report data is readily available, as is the threshold report data.
Thank you. Dr. Bunn, do you have any additions?
Well, as far as our data reports, it's all available on our KIPRC website, a lot of it, and if you want a county-specific report, there is tabs within our data tab to be able to conduct a query and get your own specific county profile report. We also have information as far as contact information to talk with someone specifically in our Drug Overdose Technical Assistance Corps who can match you up and provide you with the data that you need for your local community, region, or statewide within Kentucky.
Great. Thank you, Dr. Bunn. As I've mentioned, the slide decks and the recording of this webinar will be posted to the Foundation's website, Healthy-KY, in just a day or so. I want to thank, first of all, our presenters today for sharing all the information with us, and also to all the participants who logged in today. It's great to see everyone on the internet today and to share this information with you. I will be sending you a post-event survey. Please take a moment. I would love to hear what you thought about the webinar today. Also give me suggestions on other training events that the Foundation for a Healthy Kentucky can provide to you all. Thank you for being with us today. I hope you have a great day.
This does conclude today's call. Thank you for participation. You may now disconnect.